Hello everyone, welcome back to the PulmoCare ICU Series. I am Dr. Kalim Khan. In the previous chapter, we learned about the major components of a mechanical ventilator and the breathing circuit. We followed the path of gas from the ventilator to the patient and back again. Today, we move from the machine to the patient. Our topic is one of the most important practical skills in critical care: airway management and endotracheal intubation. Whenever we decide to provide invasive mechanical ventilation, we need a secure and reliable airway. And in many critically ill patients, that means placing an endotracheal tube. But remember, intubation is not simply the act of putting a tube into the trachea. Safe airway management begins much earlier: preparation, oxygenation, planning, and anticipation of complications. So today, we will learn a systematic approach to airway management: preparation for intubation, essential equipment, pre-oxygenation, endotracheal tube placement, confirmation of tube position, and immediate post-intubation care. Let's begin with the most important question. When should we secure the airway? The major indications include inability to protect the airway, severe hypoxemia, respiratory failure, inadequate ventilation, severe respiratory distress, reduced consciousness, recurrent aspiration, and anticipated clinical deterioration. A patient may also require intubation when prolonged mechanical ventilation is expected or when airway control is necessary for a critical procedure. However, the decision should always be individualized. Do not intubate simply because one number looks abnormal. Assess the entire clinical picture: oxygenation, ventilation, mental status, airway protection, respiratory effort, hemodynamics, and response to initial treatment. Before attempting intubation, perform a rapid airway assessment. Look for predictors of a difficult airway. Assess mouth opening, jaw movement, and dentition. Evaluate tongue size and neck mobility. Consider facial anatomy and previous history of difficult intubation. The Malampati classification may provide useful information about oropharyngeal anatomy, although it should never be used alone to predict difficulty. Today we'll cover preoperative airway assessment. First, consider the patient's ability to extend the neck and measure the thyromental distance. Also check for facial trauma, airway swelling, blood secretions, obesity, and anatomical abnormalities. In an emergency, however, airway assessment must be rapid. Never allow prolonged assessment to delay a life-saving airway intervention. One of the most important principles in airway management is to anticipate difficulty before you begin. Can I intubate this patient? Can I ventilate this patient if intubation fails? And most importantly, what will I do if both intubation and ventilation become difficult? This is why every intubation should have a backup plan. Plan A is your primary airway strategy. Plan B is an alternative method of oxygenation or airway management. And you should always be prepared for a failed airway scenario requiring emergency rescue techniques according to your local difficult airway protocol. Now we come to one of the most important steps: preparation. Never begin an emergency intubation without preparing the equipment and team whenever the clinical situation allows. Check these steps before intubation: the oxygen source, the suction, prepare the laryngoscope or video laryngoscope, select an appropriate endotracheal tube, check the cuff, keep a stylet or appropriate introducer available, prepare a bag valve mask device, have alternative airway devices immediately available. Prepare monitoring, pulse oximetry, ECG, blood pressure, and preferably continuous capnography once the airway is established. Prepare the medications for induction and post-intubation sedation. Tailor the dosage to the patient's condition and local protocol. Before intubation, one of our most important goals is to maximize the patient's oxygen reserve. This is called pre-oxygenation. During the period of apnea associated with induction and intubation, the patient cannot effectively ventilate. The method of pre-oxygenation depends on the patient's condition. A cooperative patient with adequate spontaneous breathing may be pre-oxygenated using a well-fitting oxygen interface. Patients with severe hypoxemia may require more advanced oxygenation strategies according to the clinical situation and local protocol. Do not rush into intubation while ignoring oxygenation. Prioritize oxygenation first for safer patient outcomes. Once the patient is adequately prepared and pre-oxygenated, medications may be administered according to the chosen rapid sequence or modified intubation strategy. The choice of induction agent and neuromuscular blocker should be individualized based on hemodynamic status, neurological condition, bronchospasm, and other patient factors. After induction and adequate muscle relaxation, the laryngoscope is introduced carefully to visualize the glottic opening. This step is critical for securing the airway. Now comes one of the most important steps of the entire procedure: confirmation of tube placement. Never assume that visualization of the tube passing through the vocal cords is enough. We must use secondary confirmation methods for every intubation. The most important method for confirming tracheal placement in a patient with a perfusing circulation is continuous waveform capnography. A persistent appropriate exhale carbon dioxide waveform strongly supports tracheal intubation. Also assess bilateral chest movement and breath sounds, oxygen saturation, and clinical response. Chest radiography may be used after intubation to assess tube depth and identify complications such as mainstem intubation or pneumothorax, depending on the clinical setting. Remember, auscultation alone is not sufficient to reliably exclude esophageal intubation. After confirming tracheal placement, we must ensure that the tube is at an appropriate depth. A tube positioned too shallow may become displaced or accidentally extubated. A tube inserted too deeply may enter a main bronchus, most commonly the right main bronchus, resulting in reduced ventilation of the opposite lung. Therefore, tube depth should be assessed clinically and confirmed according to the available monitoring and imaging methods. The endotracheal tube cuff provides a seal between the tube and the tracheal wall. The cuff should provide an adequate seal while avoiding excessive pressure on the tracheal mucosa. Overinflation can contribute to tracheal mucosal injury, while an inadequate seal can cause air leakage and increase aspiration risk. Therefore, cuff pressure should be checked using the appropriate cuff pressure manometer when available and managed according to accepted clinical practice and device recommendations. The procedure is not finished when the tube enters the trachea. Post-intubation management is equally important. Connect the patient to the ventilator. Confirm appropriate ventilator settings. Continue oxygenation and ventilation monitoring. Provide appropriate analgesia and sedation. Reassess blood pressure because induction and positive pressure ventilation can cause significant hemodynamic changes, particularly in critically ill patients. Check tube position and secure the tube properly. Obtain an arterial blood gas when clinically indicated, and reassess the patient's respiratory and hemodynamic status. Now let's discuss complications. Airway management can be associated with serious complications, including hypoxemia, hypotension, aspiration, dental trauma, airway trauma, esophageal intubation, right mainstem intubation, pneumothorax, arrhythmias, and cardiac arrest. One particularly dangerous complication is prolonged apnea and hypoxemia during a difficult intubation attempt. This is why repeated unsuccessful attempts should not continue indefinitely. There is one airway emergency every clinician must understand: the can't intubate, can't oxygenate situation. This occurs when conventional intubation fails and adequate oxygenation cannot be maintained with available non-invasive or supraglottic techniques. This is a true airway emergency. At this point, the priority is oxygenation, not repeated attempts at the same technique. The exact technique should follow your institutional difficult airway algorithm and local guidelines. Let's create a simple mental checklist for every intubation. Recognize the indication, call for help, assess the airway, prepare equipment and medications, optimize the patients and pre-oxygenate, have a backup airway plan. Perform intubation by visualizing the vocal cords and inserting the tube. Confirm tube placement with waveform capnography and clinical assessment. Secure the tube, then start ventilator support, sedation and monitoring. This systematic approach is much safer than simply picking up a laryngoscope and attempting intubation without preparation. Let's quickly revise today's chapter. Airway management begins with recognizing the indication for airway control and rapidly assessing the patient for difficulty. Preparation is critical. Oxygen, suction, laryngoscope, endotracheal tube, alternative airway devices, monitoring, medications, and backup plans should be ready whenever possible. Preoxygenation is essential because it increases the patient's oxygen reserve before the period of apnea. Secure the endotracheal tube to prevent dislodgement. Assess the cuff pressure to avoid tracheal damage. Connect the patient to the ventilator. Provide appropriate sedation and analgesia. Continuously monitor the patient. And finally, remember, a successful intubation is not simply placing a tube. A successful intubation means securing the airway safely, confirming its position, maintaining oxygenation and hemodynamic stability, and immediately providing appropriate post-intubation care. So, in today's chapter, we learned the complete approach to airway management and endotracheal intubation, from recognizing the need for airway control to preparation, pre-oxygenation, intubation, confirmation, and post-intubation management. In the next chapter, we will finally enter the heart of mechanical ventilation, initial ventilator settings. We will discuss how to choose tidal volume, respiratory rate, FiO2, PEEP, inspiratory flow, and other essential parameters, and, most importantly, how to choose them according to the patient's clinical condition. If you're following the PulmoCare ICU series, don't miss the next chapter, because this is where the theory starts becoming practical ventilator management. Thank you for joining today's lecture. I am Dr. Kalim Khan, and this is the PulmoCare ICU series. Keep learning, keep questioning, and keep saving lives. I'll see you in the next chapter.